So hello and welcome everybody. It's now 6:15, so we'll slowly get started. Welcome back to the ETH and SSPH Plus lecture series, which is This is Public Health. Hopefully you've been joining us. To those of you who had a break recently, welcome back to the final lecture of the lecture series. And as you know, my name is Emily Reeves. If you've been following the lecture series, then that's how you'll know me. Otherwise, if you haven't, then you might know me from the SSPH Plus at Expo project, which I have been talking to you a little bit about through this ETH lecture series, and encouraging you to download the QR code and just have a go at the quiz that we have developed. So the SSPH Plus community has developed this quiz on health in all sustainable development goals of the United Nations. So for the very last time of the lecture series, I can once again encourage you to download the QR code. So if you haven't done so for the duration of the lecture series, now is your final chance to download the QR code and play. And feel free to send me your feedback to the quiz to my email address, which I have listed there. As usual, I also highlight the link which you see there to student services which are available for anybody who is currently impacted by the circumstances and events that are taking place in our world right now. It is a difficult time and there are many things going on at the moment, so please don't be under-supported. Do reach out to the student services that are available for you. I've listed the ETH student services that are available, but there are also many more similar services available at many universities across Switzerland which are similar. So please feel free to reach out that way. Otherwise, please get in contact with me and I'd be more than happy to redirect you. So as I mentioned, this is actually the final lecture of the lecture series, which only leaves me to introduce the lecturer today, who is Dr. Stefan Cullati, and he will be talking today about You Are What You Have Done throughout your life, how reliable our life course influences on healthy aging. So this is the topic that will be addressed today. Dr. Cullati is a senior lecturer in epidemiology and public health. And he's based at the University of Fribourg. He's a medical sociologist at the Division Quality of Care, Department of Readaptation and Geriatrics at the University of Geneva. So it's a real pleasure to have you here with us, Dr. Cullati, and I hand the word over to you.
Thank you very much, Emily, for this introduction. My name is Stefan Cullati, and so I'm senior lecturer in epidemiology, and I'm mainly working at the University of Fribourg at the PopF laboratory, making a life course epidemiology. So the topic of this presentation is mostly related to life course epidemiology, and I would like to introduce you to this approach. So let me share my screen with you. Also, just before that, I'll let you know that you can interrupt me at any time during the presentation. Feel free to stop me when you want. Okay. Sorry. Okay, can you see my full screen? Emily, could you just confirm that it's okay?
We can see perfectly, thank you.
Thank you, thank you. Yeah, sorry for this. So that's the title, You Are What You Have Done Throughout Your Life. So that the idea in life course epidemiology, we are interested to examine the long term of the exposure at specific moment in the life course, and how these exposure, for example, at the very beginning of the life course, how they could influence your health later in old age, for example. So, and I will introduce you to this approach, and the idea is to discuss how reliable are those life course influence that we can observe in research, especially in healthy aging. So I will present you some materials, empirical illustrations. So first, I will introduce you to what is the life course approach. I will present you briefly some life course models, not all, but some of them, and provide some empirical illustration from some of them from my own research, and also to criticize those research, so my own research, and the potential pitfalls that we could have. So that's for the plan. So let's start with the life course approach. It was born in the 1970s. So the label of having life course approach was born in the 1970s, starting with some scholars starting theorization about this approach. And the target was to understand the human development of the people. And it was at the crossroad between the biography of the people and their history. And as a big example is the book of Glenn Elder, published in 1974, Children of the Great Depression. And it was a study about the children who grew up during the Great Depression. For some of them who grew up in a very tough and very difficult socioeconomic condition, and what could have been the impact for the rest of the life course in terms of educational achievement, employment trajectories, and also health. So the idea was that your biography, your trajectories of the life course could be influenced by macro level influences for the Great Depression. Okay. The idea in this approach is that we are interested by the longitudinal perspective. So we recognize the value of the longitudinal orientation. We are interested by longitudinal data and to see how the people can change, can evaluate over time. It's a fundamentally interdisciplinary approach. And so there are different which discipline are included or not included, but coming from the handbook of the life course of Michael Shanahan from Zurich, the big idea could be that we could put in the life course approach social sciences, including psychology, sociology, demography, history, geography, natural sciences, and social epidemiology. Personally, I'm at the crossroad of social sciences because my background is in sociology, medical sociology. And over my career, I made a lot of epidemiology and life course epidemiology. So I'm in between social epidemiology and sociology. That's it. The life course, some terminology. The idea that the life, you can see or read two different terms, the life course approach or the life course perspective. Both terms are equivalent roughly. So it's like synonym. You can consider them as a synonym. The life course approach or perspective, I will mainly use the label life course approach, is not a scientific theory. It does not postulate, it doesn't make a hypothesis based on postulates and then empirical test. But the life course approach, so it's not a scientific theory, it's an approach, it's a perspective. What does it mean? I will explain to you 5 principles about that. But the first idea to have in mind is that the life course approach, generally speaking, it's about complexity. We deal with complexity because of the, as you can imagine, we're interested by long duration of follow-up in the life course of people. And during long duration of follow-up, it could happen many things in the life course of the people. A lot of factors could be there and influence the life course of the people, or could influence the outcome on which you are interested. And if you do not have the data, you always have the risk that you will miss some factors that could influence the outcome that you want to study, but you do not know that because you don't have the data. So life course approach is to accept the complexity and to work with it. We will come back again about this idea of complexity. So what is the approach? If it's not a scientific theory, what is it? So there are 5 principles to characterize the life course approach. Those 5 principles come from one book that you will find later in the reference. There are other scholars who identify 6 principles. So the idea is not to compare which one is the best one. Just to let you know, it's not the main, it's not the single way to define the life course approach. There are 2 or 3 scholars who are identifying most of the time the same principles. They are very common across scholars. So I took the most simple 5 principles. The first one is the idea of the development of the life course. We are interested by the human development, and the human development could be biological, could be psychological, or social, or all of them all together. We're interested by human development, how people grew up, and also how they are aging. And we are interested by the lifelong processes that influence the development, that influence aging. Ideally, we would like to study the entire life course from gestation to death, but we need the data for that. It's not always evident to have full data over the life course. The second principle is time and place. And come back to the book of Glenn Elder, you can understand that this principle is relatively evident for children who were born during the Great Depression. The idea of historical time and place, the country were deeply impacted by the Great Depression. So place and time could be very important. So when you have this perspective, you are most of the time interested by comparing the life of people living at different moments in the history of one country, or at the same moment but across different countries, or a combination of both aspects. Then the third principle is timing, and this one is very important. The idea is the when the exposure is coming in the lives of the individual in early life, childhood, adolescence, young adulthood, middle age, old age. The idea is that when the exposure arrives, for example, exposure to pollution, this could have different impact, different consequence, positive or negative, depending on the timing of the exposure. Yeah. Again, this exposure could be biological, so pollution could be psychological or psychosocial. For example, stress, very stressful environments at work or in the family, or it could be at any time or different, or it could be social stress or different type of exposure. The idea is the timing, the when is the exposure. The fourth principle is linked lives. The idea is that it's not very original, but it's important for the life course. The idea is that we are influenced by the people who are close to us. So people in our family, it could be also people in the close neighborhood, people in your close network, so family, entourage, friends, co-workers, sometimes your religious community, and that's the idea that we are strongly influenced by them. So it's not very new. Psychology, sociology are interested by this aspect. Here, with the life course perspective, we acknowledge the importance of this, but we are interested by having a longitudinal approach and seeing how people mutually influence each other, for example, their mental health in couples. I made some study about that, but I will not present them. You can select in panel database people living in couples, and you have the same measurement of their mental health at different waves, and you can examine the influence of each other over time. That's the idea. And the last principle is agency. The agency is simply the idea that we are interested by many factors that influence the people, structural factors, external factors, environmental factors. And the idea is not to end up by saying, okay, we are determined by this, and this, and our life course is simply the sum of many factors. The idea is agency is that people have some freedom, the freedom of thought, the freedom of behavior, of course, and also they have resilience. They have also some plasticity, so they can have their own life course and live within social structures, historical circumstances, but they have a capacity to adapt themselves when they are exposed to dramatic event or negative life event. So the agency of the people is an important factor that could modify the life course, of course. So the idea is that we have to acknowledge this part and not to say that the life course is just the sum of a list of factors. Okay, let's go to a definition of life course epidemiology. I give you two definitions. The one which is the most common comes from Diana Koo and Yoav Ben Shlomo in the book A Life Course Approach to Chronic Disease Epidemiology, published in 1997. And they provided this definition: life course epidemiology is a study of long-term biological, behavioral, and psychosocial processes that link adult health and disease risk to physical and social exposure acting during gestation, childhood, adolescence, young adulthood, or through the generations. So with this approach, with this definition, we are in an approach more focused on health levels or onset of disease in a single time. For example, in adulthood at the age of 40, you want to see how many people have a chronic disease, and then you want to link this outcome. Having yes or no chronic disease at the age of 40, is it related to some characteristics during your gestation, your childhood, adolescence, etc. Yeah. So here, generally speaking, this approach, your outcome is a single measure. It's measured once, for example, at the age of 40 or at the age of 50, etc., etc. Another approach is from a book, A Life Course Perspective on Health Trajectories and Transition, from Claudine Burton-Jongro as the first author. In this book, we describe the life course epidemiology. We define the life course epidemiology as the way in which health behaviors and psychosocial and economic resources constitute area of action by which individuals influence their health over time and in the socio-historical context of their time. The idea, what is important here is the idea of trajectories of the health over time and how the health is changing. So in this approach, we are more focused on health change or trajectories, meaning that the outcome, health, is repeatedly measured on the same individual. And we have longitudinal trajectories on the outcome. That's two big definition of life course epidemiology that I identified. But we can add also other definition of life course epidemiology from other scholars, especially in the US, Alphon, about that. But the idea is not to go into too much details about definition. Just to let you know that public health, because you are a student in public health, is becoming more and more interested by the life course approach. For example, the life course approach to mental health is expanding in public health and also in health promotion. Just to give you an example, those three reports, books or reports from public health or health promotion institution. The first one, a life course approach to health, the implication for training of embracing. A second one, it was about the impact, the role of nutrition and on dementia. But in this report, the life course approach was very important, but it is in French from the Swiss Health Promotion Foundation, mental health over the life course. So the life course approach is expanding slightly, not a lot, but slightly. So let me introduce you to some life course model. So if we come back to the Kuh and Ben Slomo definition of life course epidemiology, we are here in the approach of we are interested by a disease or poor health at the end of the follow-up of your study. So in one moment of the life course. And for this approach, we can identify three models: the critical/sensitive period from Barker, the accumulation of risk model, and the pathway model. To illustrate visually those different models, we made a publication with Cornelia Wagner. She is a PhD student in SSPH+. She made a very good publication based, and we analyzed multi-morbidity at the light of the life course model. So we define those models like this. So you can see the critical period here is the idea that this is childhood, this is adulthood, and this is old age. And this, you cannot see my mouse. This is childhood, adulthood, and old age. And the critical period, the idea is that only childhood will influence old age, and adult will not influence old age. Childhood could influence adulthood, of course, but that's not the idea. That's another model, let's say like that. That's how we present the critical period. So the influence of childhood is crucial, and the other influence that could come later in the life course, like in adulthood, are not influencing the outcome. The sensitive period model is very close to the critical period model. It's simply that it's the same, but adulthood can also influence your outcome, your health in old age. So you have two influences: childhood plus adulthood. The pathway model is a bit slightly different, but the idea is that adulthood is could be a critical period between childhood and old age. And here you are more close to a mediation model. It's also called a chain of risk model. The idea is that childhood influence adulthood, which in turn influence old age, but you have no influence of childhood on old age. And the last one is the accumulation of risk, saying that you have childhood, which influence adulthood, old age, also adulthood influencing old age, but no influence of childhood on old age. That's how we can define the different life course model when you are interested by health status in a specific moment of the life course. Here, for the illustration, health in old age. Now, if we come back to the second type of approach in life course epidemiology is about health development or health trajectories. We have also the critical and sensitive period model. And we have the Strachan, sorry for the pronunciation, model, and the reserve model. So the Barker model, which is critical and sensitive period, is about that. So here the idea, we plot the trajectories of two people, A and B, and you can see here the level of body function or the level of systems. Broadly speaking, it is the level of health. And the Barker model is interested by the phase of development in the life course. So it's not related to the rest of the life course. It's making hypotheses about these phases. And it's saying that it's possible that very, very early in the life course, during gestation or just after birth, you could be exposed to a negative factor, so a pollution or a stress, something not good for you. And we can imagine that here, the participant B was exposed at the time of birth. And the Barker model predicts that here we have development which will be less good compared to the other participant, A, who was not exposed to the factors. So different rate of growth for those two participants, meaning also that at the very end, they will reach, at the end of the developmental phases, peak level with a gap in terms of their level of body function or level of health. That's the Barker model. The idea of this Barker model is that this gap in the level of body function or systems will be the same over the life course. It should be constant. So if the difference remains constant over the life course, then it's more, let's say, a critical period model. If the difference is diminishing because the participant B is able over time to recover a little bit, to train himself to have a lot of health behavior, positive health behavior, physical activity, good, and maybe he could be able to recover, and then the difference will diminish over time, and then we speak of sensitive period model. The sensitive period model is simply that the difference is not constant, and that meaning that the exposure in very early of the life course is not irreversible exposure, has no irreversible consequence over the life course. It's possible to get over. Now, the Strachan model, which has been revised by Kuh and Ben Slomo in their book, A Life Course Approach to Chronic Disease Epidemiology. In the Strachan model, we are more interested by this phase of the life course, the phases of aging. Here we have three people, A, B, and C. And the Strachan model is interested, so you are interested by what is going on at the beginning of the follow-up, at the beginning of their life course. That's the baseline level. People can start their phase of aging at a different level. And we are interested first by how the people will change over time, meaning during the phase of aging, we will slowly decline our health status. In what we are interested to look for is that some people, so the age at onset of decline could be different across people. And we are interested to explore those differences. For example, the participant A starts the decline here around the age of 25, whereas the participant C maintain the top level of his health, but start to decline later at the age of 50, something like that. This is purely artificial, just to illustrate that could be a first part when you are interested by trajectory to study differences in terms of age, of when the health decline will start. And you could be also interested by different rates of decline, with some participants who will decline more quickly than others. Here, for example, participant B, during this period here, the participant B have a higher rate of decline compared to participant C, who is declining very slowly in this period of the life course. Yeah. And you can also imagine with this model to study how it could be possible that at baseline, the four participants, A, B, C, and D, are exposed to pollution or to stress or to adverse events, but they will have different trajectories. So you could be interested to study the viability of the trajectories of those four participants. That would be, and try to explain why there is those variation in the trajectories. And then we have the reserve model of Ben-Shlomo. The idea is that the Strachan model is probably a very big simplification of what is really going on in our body when we are aging. And Ben-Shlomo and Yanaku proposes the reserve model. The reserve model is that, okay, we are aging, we reach the peak level of our health, and then we are exposed to a succession, many risk factors over the life course, and we will decline slowly, but we are exposed here, then we decline our health level, but we come back a little bit again, thanks to the reserves of our body, for example. It's for example, we have in our organ, for example, the kidneys, different organ of your heart. We have a reserve function when the organs are attacked by a virus or a bacteria. They can resist to this infection by slowing down a little bit their function, but maintain the function during the time which is needed to fight against the virus. So they are using their reserve function. This is called the physiological function. The organ is reducing a little bit its function, but it is still functioning until the infection is passed away, and then he can recover his normal level of functioning. So that's the idea. But the idea is that over time, so we recover, but then we are exposed again and again. And over time, we are diminishing the level of body function. And that's the process, that should be the process of aging. Based on this, I propose this a biopsychosocial reserve model of the development of health vulnerability over aging, considering the fact that this model is simply saying, based on the Ben-Shlomo model, that it's important, to have, so we can maintain the best function of health thanks to the resource that we have, and we propose to distinguish between functional resources and reserves. Both are two types of resources, but the reserves are crucial to maintain good health over the life course. And we propose a multi-dimensional approach of reserves. So we have brain reserves, physiological reserves, cognitive reserves. Psychologists are very well known about this concept. Relational reserves comes from sociology, and economic reserves, your bank accounts. Based on all of this, the idea is that if you maintain your level of reserves, you will be able to go through the numerous adverse life events on which you will be confronted during your life course. So here you have two participants. A, it's purely theoretical, as he is exposed here to an adverse life event. He decreases his level of reserve, but then he's able to recover and regain his baseline level of reserves. Then when he's exposed again to a second adverse life event, he will reduce his reserve, but then recover his baseline level of reserves. And then he's over the life course, always protected because he has good level of reserves to get by through the adverse event. However, the participant B is not able to recover. So he's decreasing after each adverse event his level of reserve until he will cross the breakdown line and experience physiological failure, psychological impairment, or social exclusion, depending on what you are studying. So that's the reserve model, and also this model needs very intensive longitudinal data to be able to measure participants over the life course with a lot of data, repeated measurement on the same people. So let's talk now about life course influence on health trajectories in old age. It comes from this project that I had the chance to lead, the influence of life course on health trajectories in old age. It was based on the shared data. So the idea is that people were followed during this period of their life course after the age of 50 plus. They were and so we have a longitudinal follow-up during this phase of the life course, and we have a lot of information about the previous life course, when they were young, their employment trajectory, things like that. And what we show that in this project is that early life socioeconomic circumstances were associated, with all domain of health. For example, physical health, we saw, a big association with muscle strength, with peak flow, so lung function. We saw association also with cognitive function, delayed recall, verbal fluency, and also with, let's say, emotional health, like depressive symptoms and well-being. And we saw also this influence with frailty, disability, body mass index, and self-rated health. And then what it was interesting to see is when we adjust with adult life socioeconomic circumstances, like educational achievement, main occupation, and income in old age, we thought that those lines will be broken, will be cut by the adult life socioeconomic circumstances. It was not the case. It was not the case for all of these outcomes. So it was amazing to see that early life remained a robust predictor with a nice gradient across the different, it was a score of 5 or 6 categories. Across the category, we had a nice gradient between the category of early life socioeconomic circumstances. So it was robust to adult life socioeconomic circumstances. And also we had the possibility to adjust with many other risk factors related to each specific outcome. But this was when we were interested to examine health level. So your health status at a certain age. And then we wanted to see if we could also observe this influence of childhood poverty. In other words, this is childhood poverty on health trajectories. And we saw nothing. Only one association between childhood poverty, early life socioeconomic circumstances, and delayed recall. And it was robust to adult life adjustment with adult life socioeconomic circumstances, but otherwise no association with muscle strength, no association with peak flow, with depressive symptoms, well-being, nothing. Yeah, and probably maybe also it's not a reliable, robust association. We do not know exactly what happened. So in conclusion, with this project, we saw health disparities in old age, okay, but with a big difference between your status of health status at one point in your life course, and your evolution, your change, your trajectory. It was completely different. Health trajectories were almost parallel in the second half of life. And even they were, by some way, converging at the very end of the life course. So what we saw is that most of the lines were parallel in the second half of life. Is it a selection effect? Because we can ask us why we did not see differences between the curves, people having accelerated decline compared to other people having a slower decline compared to those to other people. Why possible we have selection effect in this data? We are not sure they are fully really parallel over time. But what we can say is that we observe in terms of level status big differences between people according to their whether or not they were born in a poor family, poor household in their childhood. So childhood create a gradient disparities in terms of health status for physical health, mental health, cognition, etc., frailty, disability, blah, blah, blah. We saw those differences in the second half of the life. And what we can say is that these differences existed before the age of 50, but we have no data here on this part of the life course in terms of health, I mean. So what we can say is that those differences that we can see and which are parallel over time, maybe they should be developed during the developmental phase, so the early life course, maybe they were developed in young adulthood and early middle age. It's possible. We do not know exactly. But this result, despite we have no answer about this part of the life course, suggests that the sensitive period model may be appropriate because at some times of the life course, the differences that we can see in old age were created. We do not know when, but at some times they created. And they persisted over the life course. Okay, childhood can be an important predictor of health disparity in old age. Another example, which is quite well known and comes from, it was a systematic review published, a meta-analysis published in Lancet Public Health about the influence of adverse childhood experiences and mental and physical health in adulthood, not old age, adulthood. So what is adverse childhood experiences? This include a lot of different things, but mainly physical and emotional abuse, neglect, and home dysfunction. And all of these adverse experiences were occurred in your childhood. Yeah. So if you were exposed to many of them, of these adverse experiences, then you are at higher risk of depression, perpetrated violence, anxiety, attempted suicide, low life satisfaction. That's for mental health. You can see the pooled odd ratio, but also the heterogeneity. So we see association, but the heterogeneity is very high, and the number of studies at the end is not very also high too. Except for low life satisfaction, no heterogeneity across the 5 studies included. So maybe this estimate is a little bit more reliable, but we have to be very careful. And for physical health, diabetes, overweight, obesity, cardiovascular diseases, cancer, you can see also important associations. Effect size are odd ratios, are quite important, but also again with a lot of heterogeneity for obesity, overweight. Not so much zero heterogeneity for diabetes and cancer, but not a lot of studies. But this review is, however, no association with physical activity. So that's maybe an indication that this association between adverse childhood experiences and mental health and physical health maybe does not go through the health behavior like physical activity, but we do not know now for the moment. Okay, we have this big meta-analysis saying that we have a link between adverse childhood experiences and health in adulthood. Okay, it looks relatively interesting. A beginning growing level of evidence about this association. However, so we have this association. Early adverse life experiences are associated with mental health. So if we go into more details, for example, adverse experiences in adolescence and depressive symptoms in the second half of life, between the age of 50 and 90. So based also on this meta-analysis and based on other studies, we can see this association. Okay, but there are other studies like the study of Job, published recently in Brain Behavior and Immunity, that this association is going, there is a pathway through inflammation. So adverse experiences are creating inflammation in the body, which is resulting in depressive symptoms. Another study, Read, examined another pathway, which was multimorbidity, adverse childhood experiences. So this link is most of the time mediated by multimorbidity. So the pathway should be adverse experiences in adolescence is associated with multimorbidity in old age, which then is associated with depressive symptoms. Then it becomes more and more complex. We have two potential pathways. Maybe we have a third one, which could be adverse experiences, which will influence inflammation, and then multimorbidity, which then will influence depressive symptoms. That's my own narrow that I put here, but it's possible, and we have to test this big complex pathway. That's to illustrate that in reality, we can see life course influence, for example, of childhood on your health in old age, but the mechanisms are very poorly understood, and they are probably very complex. That's one big message of this presentation. Another message is that sometimes we see association between childhood and old age and adulthood, and sometimes those associations can disappear. I'll let you know this. It was a project we conducted with 2 students of the Faculty of Medicine in Fribourg, and we were interested by the association between cesarean section and adulthood obesity. Because in the literature, we know that there were 2 meta-analyses, one published in 2013, which found a link, a risk of 1.50 odds risk of the association. So if you are born by cesarean section, you are at higher risk of obesity in adulthood. Okay, I-square was 74%, high heterogeneity in this estimate. A second meta-analysis found a bit slower estimate, 1.28 higher risk of obesity. No reporting of I-square, not good. And that's our meta-analysis that we conducted. It was an update of this meta-analysis of 2015. So we took the included studies of this meta-analysis and we updated with the subsequent studies published after 2015. And we found this estimate of 1.22. So as a first result, we could say, okay, we confirm the association between cesarean section and adulthood obesity. But you can see the I-square was relatively high, 63%. But we could say, okay, it's fine. We have plausible mechanism behind this association, which could be first alteration of the gut microbiome, or inadequate nutrition during childhood. Those two mechanisms have been discussed in the literature by some scholars. So there is an idea that, okay, this association may be plausible. For example, for the moment, it's only an association, but maybe we have one biological mechanism, one behavioral mechanism. That should be okay. Maybe that's true. In fact, it was not. We had the possibility with a meta-analysis to check if this association was maybe confounded by maternal pre-pregnancy body mass index. So we stratified the meta-analysis between study which adjusted the estimates without or with pre-pregnancy BMI. And you can see here the new estimate, which was 1.08, large confidence interval. Again, heterogeneity was much lower here, but not again. So heterogeneity I-square was much lower compared to before. So that was the first result. If you put all the study together, you have an overall estimate of 1.22, and you can maybe wrongly conclude that there is an association. However, if you have information about some potential confounding factors, you can see that in fact, this association between cesarean section, and obesity in adulthood was mostly explained by maternal pregnancy body mass index. So that's also life course epidemiology. Sometimes we have the impression that we can find association between something in childhood and health in adulthood, and we can have meta-analysis about that. But if we do not collected all the information, or if the study did not collected all information about potential confounding factors, then we can maybe wrongly conclude that there are associations where in fact they are not. And also just to remind you that, okay, I like life course epidemiology. I'm very interested to examine childhood influences on old age health, but we have to be very careful. And also there is this book published by Donald Bailey. Sorry for my pronunciation. It was a critical book about the critical period models. And in this book, the conclusion were those 3 points, whether there is an independent and direct impact of early childhood gestation of the fertile life. So gestation, if you are exposed to smoking of your mother or poor diet or things like that during gestation, that could definitely impact your development, the development of your body, and you could be in a certain way handicapped for the rest of your life. At the very beginning of the Barker hypothesis, we thought, okay, it's for life and not possible to recover, but it's still unclear according to this book. So we have to be critical. The concept of the word of critical probably is not the most appropriate term to describe the early human development. And the term of sensitive, like we come back to critical versus sensitive in the previous slide, is maybe more appropriate. Because why? The human body has a lot of plasticity. And the human people have a lot of resilience. So we come back again to the fifth principle of the life course approach, which was called agency, but you can link with the concept of resilience, the concept of body plasticity, saying that it's possible that despite you are exposed in a very sensitive period of your life course, which could be gestation or very early childhood, people are still able to recover, to get back, to get by, sorry. That's the idea of this book. So to finish this presentation, the take-home messages are first, well, very simple. If you like to work with an interdisciplinary perspective, the life course epidemiology, the life course approach is very good for you, but you are already in public health, which is interdisciplinary. So maybe you will like the life course approach, because you should like to work in interdisciplinary teams with doctors, biologists, sociologists, psychologists, etc. That's public health. And the life course approach is fundamentally interdisciplinary. Okay, that's clear. Second aspect, if you would like to put the label, this is a life course study, I made this study and this study is a life course study, what should be the criteria to say that? For me, and that's my own personal definition, it's not the most well-known definition, not at all, it's my personal definition, and you could read other scholars who will say something differently. But according to me, if you want to say, I have a life course perspective or I have a life course approach in this study, is to have at least one of the 5 principles discussed in your introduction, and to have a design with a longitudinal database or a cross-sectional database, but with retrospective data which have been collected, to have an idea of your data with a time perspective included on the same people. So if you have both aspects, one or more principle plus this type of design, then you could say, okay, I have a life perspective, and you can mention and develop it a little bit in your introduction and in your conclusion, if you are interested by life course AP. I hope I will give you some the patient of life course epidemiology. However, the evidence for long-term influences, it could seem robust, like in the Life Trade project, because we adjusted with a lot of things. We had a big sample. We adjusted for attrition. We adjusted for many things. We conducted a lot of robustness and sensitivity analysis, recording the outcome, recording the exposure. It was robust, but it's still an association. And it's not sufficient to claim causal influence at this time. So we have to wait. For the moment, it's too early to say that childhood poverty is causally influencing health in old age. It's not sufficient for the moment. So we have to be careful. And doing life course epidemiology means dealing with complexity. You have to agree, acknowledge the complexity of the life course. There could be many influences, and it will create also a lot of skepticism around you. Oh, I'm interested by childhood and the influence in old age. Wow, there are so many things. It's a follow-up of more than 50 years or 70 years. So many things factors could occur between those two moments of the life course. Stay humble. Simplify the complexity of your models. If your models, your DAG, your models are too complex, it becomes very difficult to have a nice and convincing empirical test, empirical analysis. So most of the time it's more interesting to simplify the complexity, to acknowledge this simplification, to say I cannot have make a modelization of the best complexity, of the most complex model. So I simplify it, I'm aware of that, and I contribute to the advancement of knowledge step by step, or in small steps. That's the take-home messages. Thank you very much for your attention, and I'm ready and open for questions if you have questions.
So thank you very much. Thank you for this very interesting talk, and very relevant to all of us, because of course we're all aging and developing, and we will all be going through different parts of our life course. So thank you very much indeed. We are very short for time, so perhaps we just have a few minutes left, or just one or 2 minutes for questions. If you have a question, please feel free to unmute yourself shortly. and ask the question. Otherwise, you can also ask it directly into the chat. Whilst people are thinking of their questions, if there are any at all, from my side, you had talked about reserves. So because a lot of the things that you were describing were things that kind of made, oh.
Stop. Could you repeat? Your image was completely frozen.
Okay.
Sorry.
My question was about the reserves. So because you mentioned that it's important for us to have reserves. So there were different types of reserves. How can we ensure that we do that? Is that something innate? Is that something that can be developed? Could
yes,
you...
Good question. Thank you for the question. It was something I did not develop it's mentioned in the slide. Some reserves could be in a certain way innate. Many of your biological reserves, brain reserves, some organ reserves are innate here. You could have also some, let's say, innate economic reserves by heritage. Some people, but it's not for everybody here. It's we have a variability on this. And there are many other reserves which needs to be maintained. For example, cognitive reserves, you have constantly train your brain, stimulate your cognition to maintain high level of cognition, etc. And that's a part of health promotion and healthy aging. We train all the people to make exercise, to read, or to make Sudoku, or things like that, to train their brain and maintain their cognitive reserve. The cognitive reserves protect people at the hypothesis of Jakob Stern, that if you have enough cognitive reserves, so this stimulation of your cognition, it will protect you against symptoms, against like dementia or any other mental cognitive impairment, despite you could have in your brain already some damage, which normally result in symptoms. So you can see people, they have the damage in the brain, they have no symptoms. And the hypothesis is that because they have cognitive reserves. But this cognitive reserve needs to be maintained over the life course. And the same for relational reserves, your close friends. There are some law of reciprocity in the interaction between people. So if you want to maintain people who can help you, people who can be here in case of big problems in your life, you have to, because of the reciprocity, to maintain the contact with the people. If you lose contact for many years, probably you will lose also your relational reserves. So just to illustrate that cognitive reserves, relational reserves need to be maintained. However, a bank account, your bank savings, normally, except if there are no bankrupt, these economic reserves is protected and you can use it when you want. Yeah. So different type of, you have to take care of some type of reserve while others are innate, given.
Thank you very much. Thank you for answering my question. And again, thank you very much for the talk. Unfortunately, because we're over time, it's a little bit difficult to now delve into too many questions, but I did see that on your last slide, you had your email address. And also for those who have been following this lecture, the lecture slides will eventually be up on the website as well, so you can revisit and have a look at the reading material that's also suggested there as well. In that case, I would like to thank you once again, Dr. Cullati, for taking the time to give this lecture and for this very interesting talk. And for everyone else, so all the other participants, I guess now would be time to say farewell, not only from today, but also for the lecture series, as we have now come to a close. It is the very last of the lecture series for this year, 2022. So thank you for being a part of it. For those of you who have done the last midterm exam and are waiting to do the next one. Just a short notice on that, the midterm exam will be uploaded sometime after the 7th of June. The exact date and the details will be communicated to you via email, but the format and all the details will essentially be the exact same as they were for the midterm exam. So you can find the exam on Moodle, you will have the same amount of time to complete the exam. And so all the processes will be very much the same as they were for the midterm exam. But I will send you out an email so that you'll be able to see all of this in a concrete way. And in the meantime, if you have any questions, please don't hesitate to get in contact with me via email. So then, without further ado, thank you very, very much to Dr. Cullati and to all of you who have been present.
Thank you very much for the opportunity to give this presentation. Very happy for that.
Thank you. All the best and wish you all a nice evening.
All the best. Bye-bye.
Goodbye.
Bye.